That sounds great. Thank you. So I can't see the chat the way I have my computer set up. So if there's any questions during the presentation that go into the chat, uh, Stu, could I designate you to read them to me? All right, guys, can everybody see my slide? It should be, I think Trish already told me she could see it, so I'm pretty sure we're good. So we will get going then. So my name is Katherine Rizzolo. I'm a second year nephrology fellow, and I know most of you who are in the audience. I have a clinical and research interest in disparities. So I was really interested in taking the opportunity to look at what's been studied on disparities in pre-dialysis care. Okay, so let's get going. So here's our outline of our talk today. First, we're going to talk about why pre-dialysis care is important. And then we'll talk about who is not receiving pre-dialysis care. Then we'll talk about these disparities that we see in pre-dialysis care amongst people with CKD. And then the major part of our talk will be discussing what's been studied and the mechanisms contributing to poor pre-dialysis care delivery. And then we'll discuss some next steps and some possible solutions. All right, so let's get going. So these are the KDIGO recommendations for who should be referred to this nephrology clinic for CKD. eGFR less than 30, or a rapid decline in eGFR, severely increased albuminuria, hematuria, and then uncontrolled complications of CKD. And some of the examples they give are nephrolithiasis, hypertension on 4+ blood pressure agents, and hyperkalemia. Certainly we see more than this in our clinic, but these are the recommendations for when patients should get referred. And we know that this is important because there are benefits to these patients who end up starting dialysis. So in those who received pre-dialysis care before they started dialysis, they had reduced mortality in the first 6 months of dialysis. Also, those patients tend to have a higher use of home dialysis therapies, as well as a greater access to kidney transplantation, both being on the wait list and receiving a kidney. They usually have improved permanent vascular access, so they're less likely to start with a temporary tunnel line. And they have improved hemoglobin levels as well. Late referrals, which is not a clear definition, but is often referred to as less than a year before starting dialysis, is associated with poor clinical outcomes like longer hospitalizations, worse vascular access, less use of home therapies, less access to transplant, and higher mortality rate in the first 90 days. And we know that the more patients see nephrology before they start dialysis, the better. So patients who have more than 12 months have a higher awareness of dialysis modalities, are more likely to have a preemptive transplant, and are more likely to have permanent vascular access. And that's comparing to patients who had less than 12 months but did have some pre-dialysis care. There is a dialysis survival benefit. So in this study that I'm showing you here, this was done in Canada, looking at 10 different dialysis centers. And they looked at patients who had received pre-dialysis care versus those who had not, and then classified them whether they had an optimal dialysis start or suboptimal. And suboptimal in Canada was defined as inpatient start. I think they start people more outpatient there. Was defined as not using preferred vascular access, so using a central venous catheter, or not on their chosen modality. They did control that suboptimal starts are often more sick when they present. And then they grouped the suboptimal groups into early versus late, and that refers to whether or not they were referred to CKD care. So there is a benefit to starting optimally. If you look in this Kaplan-Meier curve, the solid black line is those who started optimally, meaning outpatient, preferred vascular access, on their chosen modality, in comparison to those who started suboptimally. So there's a benefit to preparing a patient for dialysis. Even for patients who don't start dialysis, there's a benefit just in CKD. So, a big job that we have in clinic is slowing the rate of decline in eGFR. So this graphic kind of shows the different things that I think the CKD clinic, the nephrology clinic can help with, including CKD primary prevention. We kind of hold that with the primary care doctors. So helping with obesity and diabetes, hypertension, polycystic kidney disease, salt intake, et cetera. I think the bulk of our work is these blue and orange bars that we help to slow CKD progression, and we help to delay dialysis transition. Helping people with uncontrolled hypertension or high salt diet. And then tertiary prevention is our management of uremic symptoms. So, CKD 4 and 5, where we're working on bone mineral disorder, fluid overload, et cetera. So we know that pre-dialysis care helps to slow the rate of decline in eGFR, and it has been shown to help with hypertension management. Interestingly, it really hasn't been shown to really weigh on other comorbidities. So for example, CKD care doesn't help with diabetes management. So it helps in both patients who start dialysis and patients who have CKD. The problem is that 35% of patients who start dialysis have no pre-dialysis care, and this is using the USRDS numbers from 2018, which is the last full set of data that we have from USRDS. Only 30% of all patients who start dialysis receive more than 12 months. And this graph shows the wide variability in geography in relation to pre-dialysis care. So the dark blue means more than 43% of their patients who started dialysis had pre-dialysis care for more than 12 months. And that light blue is the least number. So you can see it's very varied depending on where you are in the country. So because of these disparities by geography and everything else we'll talk about, in 2019, there was an executive order called the Advancing American Kidney Health Initiative. I imagine a number of you are familiar with this. And it focuses on reducing the number of incident dialysis starts. There's three main missions. And so I'm gonna focus you on this second group of boxes. So by 2030, the goal is to have incident dialysis patients reduced by 25%. By 2025, 80% of incident new starts should be on home dialysis or transplant. And by 2030, there should be more kidneys available for transplant. We'll focus mainly on the second goal here. How do we get 80% of new patients on home dialysis or transplant? Obviously, there are a lot of stakeholders involved, and down here they list a number of these stakeholders. But we know that pre-dialysis care is associated with higher rates of transplant home dialysis and reduces the progression of kidney disease. So it's very important to think about how pre-dialysis care can help us achieve this goal. So here's some of the predictors for early referral to the nephrology clinic and CKD. White race, younger age, comorbidities such as diabetes and hypertension, and then geography, like the map I showed you, where you are in the country truly matters. And that refers to US region, which is via USRDS. We know that kidney failure risk is 3 times greater in racial and ethnic minorities. This slide is from a talk Neil Poe gave. He might use this in the talk he's giving in a few weeks. But this shows from the USRDS data in 2018, the mean onset age of starting dialysis and the incidence of patients in different racial groups of how many patients are starting dialysis. So you can see it's pretty clear cut that patients who are Black start earlier, and there are disproportionately more of them. Patients who are identified as Hispanic, which I should say in USRDS is done as an ethnicity and not a race, also has a pretty high number in comparison. So we also know that race is associated with different rates of eGFR decline. So this this graph is showing that patients who are Black, which is identified on the graph by a solid line, tend to decline in their eGFR faster than those who are white. So we have less time to get these patients into our clinic and treat them before they start dialysis. This is USRDS data from 2018 showing the percentage of incident patients who had 12 months or more of pre-dialysis care. I should say when it's under 6 months, the rates were pretty even. It was about 20% in each race. But once you go up to about a year, which we said has a benefit, the longer the better, it's much less likely that patients who are Black are going to get pre-dialysis care compared to those who are white or Asian. And I did not include Hispanic on this because it's classified as an ethnicity, so it's kind of, it used a different scale. So 26% of patients who are Black who have CKD see a nephrologist for more than 12 months, in comparison to about 33% for white patients. So the question is, has it always been like this? And is it getting better? Is it getting worse? So there was a study that came out in August of 2020, led by Tanjala Purnell, looking at the national trends of pre-dialysis care and these racial disparities. They looked at 10 years of USRDS data from 2005 to 2015. And this had been done before, but this was the largest study. It had more than 1 million incident dialysis patients included in it. And they took into account comorbidities, health insurance type, and type of dialysis modality to see if these trends had changed over time. And I'll give you the takeaway, they did not change over time. So looking at this box, you can see this year is in time, so starting 2005 and then moving up all the way to 2015. And well, let's look at the adjusted odds ratio because that takes into account socioeconomic status and insurance. You can see that in all categories, Black, Hispanic, Asian, they were less likely to have pre-dialysis care from 2005 all the way to 2015. So there was no improvement really in this. So the more interesting question to me is, why do these racial disparities exist?
Katie,
yes.
May I interrupt? Can you go back? Go back one slide.
Yeah.
In Black and Hispanic, was there actually deterioration? Is 0.76 worse than the 0.82 and the 0.61 worse than the 0.67?
It appears that way, yeah. So 0.67 back in 2005 and then 0.61. Yeah, it looks like it got a little bit worse.
Be going in the wrong direction.
Yes, yeah.
For those two populations, all right.
Yeah,
Thanks.
which is even worse. Okay, so the question to me is, why are there these racial disparities? And there are a lot of other disparities. We talked about other reasons why patients are, or other risk factors that cause patients to be referred early. But we're going to focus on race mainly because that's been the best studied. And we're mainly going to focus on Black patients as this is the most widely studied group. And I'm really going to try to hone in on pre-dialysis care, not disparities in CKD, for example. So we have to understand that this does not exist in a vacuum, that kidney disease and these disparities, there are a lot of causes, including environment, biology, health policy, care delivery, behavior, and then all these can contribute to development of kidney disease and disparities that we see. And this slide makes it look really simple, but this slide makes it seem how complex it is. For example, look at neighborhood, how many other things this is connected to that can impair your social determinants of health. So if you live in a neighborhood that makes it harder to access healthcare, that will then affect your access to care, for example. And so things can get very complicated very quickly. And that was the trend when I was looking this up. So I'm going to use a construct to help explain, put these these different areas that affect access to pre-dialysis care into categories. So this is from a recent perspective piece that was published in CJSON on racial inequities. And we're covering key factors that have been researched exploring pre-dialysis care and racial disparities, but understanding that even though this construct looks like there are these different boxes, they all are overlap and they all are more of a Venn diagram. The people who wrote this construct comment on that the race influences health and well-being in many health promoting factors, including education, employment, living conditions, et cetera. And so these poor access through those mechanisms can then cause, poor health literacy, greater exposure to resource constrained neighborhoods, incarceration, greater burden of poverty. These are all connected. So looking at this construct, I'm not going to focus as much on this, which is the individual demographics and health behaviors. I felt that I knew this better. It was really these four things. So physical context, and there's absolutely no way I'm going to be able to talk about every single thing they outline here, but physical context really includes the neighborhood. So building quality and safety, their transit abilities, green space, schools, access to healthcare, food, et cetera. Then there's social constructs that I'm going to focus mainly on socioeconomic status, but this also includes social influences, employment, et cetera. And then these two at the top are different levels of institution. So institutional context to me means like healthcare, healthcare, education at the institutional level. So I think of that as non-government, i.e. like the institutions that we use in our hospitals, for example. And then lastly, policy. Policy is what I think of like government policy. I decided to use this sometimes people say patient versus provider versus policy characteristics, but I wanted to kind of use this to understand how related all of these factors are. So just go with me on this one. So we're going to address physical context first. So here's what's been studied thus far looking at geography. People have looked at access to pre-dialysis care in the setting of state variability, in the setting of county variability, race makeup of neighborhood, county level poverty, Medicaid coverage, and treatment center quality. I'm going to focus on the first three, just given time. There wasn't enough to focus on all of it. Keeping in mind that dialysis facilities located in urban counties we know have the lowest rate of pre-dialysis care. These are often have a highly dense African American population and have lower educational attainment. So that's kind of where a lot of these started, looking at why that existed. Looking at the state level. So this comes from healthypeople.gov, and it's looking at state variability in CKD care. The best is this kind of like darker green. The least access is the dark blue. As you can see, we've kind of already outlined in our prior slide that there's a lot of variability by state. So one study in 2015 looked at racial disparities by state. The null hypothesis here being there is no difference by state, and it's just a pocket of the country that's making these racial disparities look quite high. And they found that racial disparities in access to pre-dialysis care was observed in every single state. So it's not a problem with certain states, it's every state this exists. And looking at this graph a little bit, they've grouped these by age. So looking at the first graph, on the x-axis, we have state level probability in white patients having access to pre-dialysis care. And on the y-axis, it's state level probability in Black patients. And this is patients under 65, which is important because that's the Medicare cutoff. And each of these dots represents a state. And as you can see, it was much less likely in almost every single state, except maybe this one right here, that Black patients would have equal access in comparison to white patients. This goes away a little bit. It definitely gets better once you're over 65. So it's much more even. So they drew this conclusion that these differences we're seeing are driven by lower rates of care amongst younger patients who are Black. And it's not necessarily the older patients who are Black. Overall, though, the likelihood of receiving nephrology care, regardless of race, depended highly on the state. But definitely these racial disparities were there in every state. And another study in 2013 looked at county variability. So they grouped counties into urban versus rural versus suburban. And this study is showing the percent of patients who had access to CKD care, and they label these patients as either Black or white. So white patients have this little white dot, Black patients have this black dot. And on the x-axis is what kind of county they lived in, all the way from urban on the left to very rural on the right. And by far, the place that everyone had the low access of care was in urban and rural places. Suburban areas had the best access to CKD care. But you can see on this graph that there were racial disparities at every place in geography, but by far the worst place was urban. There was a very big disparity between the two races, and also just in general, there was lower access. So regardless of location, Black patients are less likely to get pre-dialysis care, and it's worse in urban and then rural locations. And they took into account demographics, clinical factors, and insurance when making this graph. Then we get down to the neighborhood level. So in 2010, this group looked at racial composition by zip code and how that correlated with rates of pre-dialysis care. So overall, they noted that there were lower rates of pre-dialysis care. The higher the density of Black residents in the zip code, the lower the rates of pre-dialysis care. And so looking at this graph, understand that the y-axis in this graph is those not receiving dialysis care. And then on the y-axis or the x-axis is the percent of Black residents in the zip code. So all the way on the right is over 50%, and all the way on the left is less than 5%. Overall, the higher the density of Black residents in the zip code, the less likely anyone was to get pre-dialysis care. But you can see pretty clearly with these bars, despite the density of Black residents are less likely to get pre-dialysis care in every single racial composition of the neighborhood. So geography definitely plays a role, but it's not the whole picture. Interestingly, for those who did get pre-dialysis care, there was no difference in quality of care. And of course, I'm sure some of you are thinking, well, how does this correlate to socioeconomic status? So unfortunately in the US, race and socioeconomic status are very correlated. So this is from that same study. They looked at percent of patients below the poverty line. And this is the group that had the least number of Black residents in their neighborhood, about almost 10% below poverty line. And those who had the most Black residents in the neighborhood were much more likely to be in poverty. And it's like this straight line. So I mean, this is something that's unfortunate about the US, and lower resource neighborhoods probably have fewer health supporting infrastructures, local pharmacies, public transit. So these all kind of, like I said, it's a Venn diagram, they all tie in together. So we're going to deal with and talk about socioeconomic status next. So going back to our construct, we're going to look at social context, and I'm really going to focus on socioeconomic status. Of course, socioeconomic status has an institutional and policy component. We're just going to discuss this one as a social context. Keep in mind that in the US, 27% of Black Americans live under the federal poverty level, and that compares to about 9.8% of non-Hispanic whites. That number is from 2011. So there's a big intersection between poverty, CKD, and race. So we know patients who have a lower socioeconomic status are more likely to have CKD. They are also known to have a heavier burden of risk factors, including albuminuria, diabetes, and hypertension. We know that there's an individual level of poverty is correlated with development of CKD, and community level poverty has been shown to affect dialysis, or rather patients who end up on dialysis. They've looked at APOL1 and how that factors into neighborhoods, income, and race, and there's no association. So it seems to be a lot more about socioeconomic or social determinants. This study by Deirdre Cruz, this was in 2010, and she looked at individual poverty and by race and how this affects CKD prevalence. So overall, she noticed that individual poverty is associated with a higher rate of CKD in Black patients only. So looking at this graph, I'm going to ignore this one on the left because that's all comers. But in the middle is African Americans, and on the right is white patients. And she grouped them into lower or higher socioeconomic status. And the percentage of patients with CKD, the lighter is 3 and the darker is stage 4 and 5. And there's a pretty big difference amongst patients who are in the lower socioeconomic status for African Americans who have CKD. And this is not true of white patients. So this really seems to be a big racial disparity in that patients who are lower socioeconomic status and Black are more likely to have CKD. So we know that kind of going into how this relates to pre-dialysis care, that they're more likely to be affected. Of course, poverty and CKD are thought to be a bidirectional relationship. This is a theoretical framework, thinking that poverty can lead to CKD because of access to healthcare, segregated communities, environmental exposures, stress, discrimination. But CKD can then maybe influence the risk of poverty, higher healthcare expenditures, loss of employment, et cetera. But how does this relate to pre-dialysis care? We're going to walk through a few studies that have looked at that specifically. So by far, this is the hardest graph for me to explain or table to explain in the entire presentation. This study is from 2017, and they looked at mean household income and pre-dialysis care, and they grouped this by race. So what they did was look at the lowest and highest mean household income by quintile. Overall, the lowest mean household income, and I didn't show you on this table, I did not show you white patients, but overall, they had less pre-dialysis care, accounting for insurance type, race, employment, and comorbidities. But I want to draw you to this odds ratio. So this is the lowest mean household income. This is the highest mean household income. AA stands for African American, and then this is Hispanic. The odds ratio in comparison to white patients in the lowest mean household income, definitely African Americans and Hispanic patients are less likely to have pre-dialysis care. But then in the highest quintile, they also are less likely compared to white patients to have pre-dialysis care. So the kind of takeaway I have from the study, and this is what the author said as well, that income level is important, but not sufficient to eliminate minority gaps in pre-dialysis care. So it's definitely part of the picture, but it's not the whole thing. There was a study done a while ago, 2005. This is probably the oldest study that I have. These authors just asked patients who presented for dialysis initiation why they presented late. So they asked them, had they seen a kidney specialist, and if they had not, they asked them why they were presenting when they were presenting. And interestingly, like this is all comers, they didn't group by race, but most of the patients either said that they knew about it and they were in denial, or they didn't know they had CKD. Economic insufficiency or like financial difficulty was not the whole picture of why patients are presenting late. So unfortunately, no one's done this since. So this study is a little outdated. Of course, we know that poverty is associated with a lot of other stressors that can lead to both CKD and inability to access care. So there's biological stressors, i.e. like pollution, lead, there's life stressors, poor health behaviors, and that ties into food insecurity. So we know that's correlated with CKD. Patients who have food insecurity are more likely to have high acid diets, which can increase your progression towards dialysis. Housing instability, this has also been studied that these patients are more likely to postpone medical care even when they are aware of their CKD. We already talked about higher rates of comorbidities in this population. And then incarceration, there was just a review that came out in CJSON about this, that incarcerated patients have lots of issues with access to care and CKD. So of course, these all tie together with everything we just talked about. I can't get to all of them, but just to note that these things also factor in. With that, we're going to move to the next point in the construct. So looking at institutional context, I'm going to focus on two institutions, education and healthcare, like healthcare first, then education. And keep in mind that this area of the talk hasn't been specifically studied in how the education and healthcare institutions relate to pre-dialysis care, but they have been shown to be related to primary care. And so we'll talk about that. So primary care, they are the gatekeepers, right? They're the ones that are referring, they're the ones that are seeing the labs and have to decide when they're going to refer to us. So they're a very important piece of this puzzle. And people have looked at what the barriers to primary care nephrology referral are. So for example, there was a study in 2012 where they asked primary care doctors in an urban clinic what their barriers were, and a lot of providers said they weren't sure when to refer, they weren't sure what labs to get, etc. A big part of it is insufficient time. Providers often say they just don't have enough time to talk about CKD, and in that one study, they talked about how a lot of these providers, if they had to focus on one thing, they decided to focus on one of the comorbidities that was likely causing their CKD. So if it's between CKD and diabetes, they're going to talk about diabetes. Then there's problems with just the system. There's referral process delays. I feel we've all probably experienced that in our clinics. And then lack of communication between primary care and nephrology. Just being able to communicate what you need and want. So this is very EMR dependent. And lastly, just the clinic organization and how well the clinic is able to run. This plays a big role. So PCPs who have a high minority patient cohort often report that they have a more challenging workplace than those who do not. They have a complex patient mix and increased physician outcomes and adverse physician outcomes. So the three themes out of this study where they interviewed primary care doctors who have a high minority patient cohort, they said their work environment was more chaotic. They had less control over their work and much more hurried. They had fewer resources, including supplies, pharmacy services, and access to specialists. And they had less time, so they feel like they're not able to provide high quality care. And all this leads to physician burnout, and it can lead to just poorer care for all our patients. Keep in mind this correlation hasn't been studied directly with pre-dialysis care, but you can make the jump that primary care doctors who are seeing high minority patient cohorts may not know that they have access or may not know when to refer, and that might lead to a delay in us seeing those patients. Focusing on CKD awareness. So a couple studies have shown that patients' CKD awareness will increase with CKD severity. So patients, by the time they hit stage 4, most of them know, at least 50%. And once they hit CKD 5, almost all of them know that they have chronic kidney disease. But in CKD 3 and 2, it's much less likely that patients are even aware they have this. In one study done in 2012, they interviewed patients about their awareness, and then they asked them, about their insurance and their ability to get care. And the only real correlation was patients who had lower CKD awareness showed that they had more difficulty obtaining care. There was no association with health insurance. So, this can factor into a lot related to primary care. This study also showed that these clinicians are often more cursory and don't really talk about CKD fully, just given time and all the limitations we discussed. And they interviewed the patients after they had this conversation, and patients did not feel like they understood. So it's difficult, and this can relate to how many patients get referred to us and their understanding of what's going on. Another part of the healthcare institution, of course, and I addressed this last year in my grand rounds, is the race coefficient and EGFR. So this has been a big national discussion. But certainly this institution that we use in healthcare can cause racial disparities. So for example, this graph is showing using MDRD in these two, and then using CKD epi on the two on the right, and then looking at white versus Black patients, what their given EGFR would be at a creatinine level of 1.1. And this affects who gets referred. So certainly this institution, which has been part of our system for quite some time, also can cause the disparities in patients actually getting to see us. Kind of moving to education as an institution. So health literacy hasn't been studied directly with pre-dialysis care. Well, we know that health literacy and educational attainment are correlated. And we also know that limited health literacy is associated with a lower EGFR. In one study outside of nephrology, they looked at CPR knowledge by race and by health literacy using a validated survey that can track how health literate you are. And certainly there were racial and health literacy disparities. And once they controlled for race, those disparities in understanding CPR once they controlled for health literacy, the racial differences disappeared. So this is just from one study, probably the only one that I could find about health literacy and CKD, but essentially in the study they used patients from the CRIC study and they administered a validated health literacy survey. And first they noticed that amongst those who had lower health literacy, it was disproportionately Black patients. And also health literacy, the more limited the health literacy, the lower the EGFR. So you can make this jumping correlation of why that might be, but it ties into everything else we've kind of talked about CKD awareness and access to care. And then lastly, culture. So these are some themes that have been pointed out and why patients don't present to clinic, or what some of the barriers are for them culturally. And generally, these themes have not been studied in CKD. Most of these themes come from racial differences in presenting for cancer treatment. There was one study that did look at this, and they found that Black patients who presented later were more likely to show fatalism. So I didn't know what fatalism was. I think some people might, but just the fatalism is kind of this belief that it's inevitable, that this illness is unavoidable. But patients who are not white often talk about more negative health experiences, fear of going to the doctor, fatalism, helplessness, and then stigma of the illness itself and distrust of the medical system. So this is I already showed you this slide, but this is the same study from 2005. And there were a lot of patients who knew that they had CKD and just were in denial. And this group posited that some of these cultural differences, including fatalism, might have been at play. All right, so we're going on to the last construct now. So this is federal policy, federal government policy, and how this influences access to pre-dialysis care. So insurance has been shown to play a major role. Lack of insurance portends lower likelihood of pre-dialysis care. So this study was in 2014. They looked at access. They looked at a lot of things. But one thing they looked at was nephrology care access by insurance level. So this dark bar is private insurance. This white bar is uninsured, and this middle one is Medicaid. And this is the percentage of patients who are able to get pre-dialysis care. Keep in mind that in this study, the private insurance group, only about 30% of them are Black. In these two other groups, the Medicaid and uninsured, they made up about 50%. So white patients made up the majority of those with private insurance. So Black patients are more likely to be in this group, first of all. And then these disparity gaps go away with the onset of CKD because they transition to Medicare. And so even though some of our prior data has shown insurance doesn't play a role, it certainly plays some role. It doesn't, our prior studies show that insurance doesn't play the predominant role. Medicaid expansion has been shown to increase rates of pre-dialysis care. So this was a 2018 study that looked at USRDS data pre and post Medicaid expansion. And what they saw is Medicaid expansion overall shows higher rates of pre-dialysis care. This dark bar is in expansion states, and this percentage is the number of patients who received nephrology care prior to dialysis. Notably, this number is pretty high in comparison. And the non-expansion states, there was definitely fewer. Overall, people are getting more dialysis care, pre-dialysis care. But notably, the racial differences here is that in non-expansion states, Black patients make up about 40% of the cohort. And in expansion states, they only make up about 27%. So Black patients are more likely to be in states that did not expand their Medicare. And this ties back into geography. Interestingly, for those who are VA in the audience, this was shown in a couple studies that racial disparities in pre-dialysis care are eliminated with VA healthcare. So the same study that showed that mean household income did not really increase pre-dialysis care in minorities also showed that having insurance and having VA insurance was very important to having to eliminating racial disparities. So this is the odds ratio here under VA insurance for African American and Hispanic patients. And they were actually, if anything, a little bit more likely to go to have pre-dialysis care. And so, you know, what this shows is that this isn't just an issue with certain states. This is definitely kind of an issue across the country with insurance, because if it's eliminated in the VA across the country, then it can't be a state-by-state issue. I would be reticent to not talk about how racism impairs every single thing we've talked about. So for example, there's different forms of racism, both on the implicit bias scale from different providers to structural and institutional racism to cultural. So for example, looking at structural and institutional, an example here is how deeply socioeconomic status and race are embedded into our history. So the neighborhood example, going back to our first set of constructs, redlining caused racial segregation way back in the mid 20th century. And then where you live determines your healthcare access, and that determines your pre-dialysis care. So all of these are related, and understanding that racism is in every single one of these categories is, I would be remiss to not mention that this is factors in every single category we've probably talked about. Okay, I'm going to move on to some next steps. So what do we do with this information? And I'll be honest, these are my own thoughts. I tried to focus on things that I thought we as healthcare providers in nephrology could think about. It would be well above the scope of this talk to discuss how to fix poverty and racism. I'm just going to focus on things nephrology providers can think about. And these are largely my own ideas, so I'm open to anything you guys have thought of. So for example, care delivery. So improving care delivery, especially in urban areas. An example that I thought of immediately was Boston Healthcare for the Homeless. So this was just, somebody gave a talk to us in medical school about this, and I thought it was incredible. It's a group in Boston that has really focused on how to deliver healthcare to the homeless population. They put clinics in shelters. They also take vans out at night to deliver medicines for patients who can't or don't want to go to a clinic. And they've really improved care delivery in Boston. I'm sure there are others like this. This is just one I'm familiar with. So improving care delivery of how do we get our patients into our clinics? Community-based, culturally sensitive care approaches. So a big one is kidney transplant. For example, at Northwestern, this group has focused a lot on how to improve access for Hispanic patients, getting transplants and getting on the wait list through a language and culture concordant program, and they've shown dramatic increases in this. Another one, you guys might remember the study from 2018 was in hypertension. This group went to barbershops that were predominantly Black people, and they did hypertension management in the barbershop. And it showed great improvements in having people have access to care. So that's one kind of area of improvement. Another one, a big one, is how we work with our primary care colleagues. So first of all, recognition could be improved. One option is electronic decision support, an automatic kind of alarm, something. There are always mixed feelings about that, but that is an option. Patient education. One study talked about a CKD education team. So, and we kind of do this at Denver Health. Like if a patient has CKD, we then have our nurses and come talk to them a little bit more about CKD. And so that doesn't take up all the providers' time in trying to educate this patient on a very complex issue. Communication between teams as well, just improving that. I'm sure there are lots of ways to do that. And then addressing unmet needs, for example, getting patients into care. So one study looked at, they did on-site scheduling, on-site testing, and that improved patients' abilities to get labs done and to schedule their appointments. And then just meeting basic needs, putting a social worker into clinic, for example, to help patients get access to rides and food, et cetera, can increase our ability to help them with their kidney needs. And lastly, areas for improvement in the policy sphere. We as physicians especially are in a very powerful role to advocate for improvement. So we can advocate for improvement in access to care, eliminating discrimination, and improving insurance and reimbursement. So an example of this was this NKF ASN task force that looked at the race and EGFR equation. It was a group of like interdisciplinary nephrology providers who kind of met on a national level and are working to change policy. So hopefully all of those areas are things we can think about to improve access to pre-dialysis care and eliminate these disparities. That is all I have. And these are my references, and I'll take any questions.
Thanks, Katie. Sorry I joined late. Just a little bit about the ideas that you suggested while you're here in Boston. I think you are aware, and many of the faculty are actually working at the Dawn Clinic that actually serves patients from the Aurora area who are uninsured. I know Judy is not on the call, she's on study section, I think. But Anna, I know, has been involved, and I think Sophie also. And I don't know if anyone wants to say something, but it's a very powerful way of us helping and making an impact, as you were mentioning.
So I thought that was really good. I had just questions about, there was this shortening of time that you said between like the decline in GFR towards needing dialysis. And it seems like there's probably something we can actually do about that. So it just seems that, this right here, instead of just saying, oh, our time is like shorter in African Americans, their decline is going to be faster. It seems like there's probably something we can do as far as like more improving our preventative care. And that probably comes from more of a primary care aspect as well. And then I really appreciated the understanding that this in this denial, there's this culture of distrust, because I feel like that's missed a lot. And there's a lot that we can actually do about that as well. And it starts with having actual representation in medicine, and as far as kidney disease, kind of reaching out from that standpoint, but also kind of other areas of kind of reaching out to the Black communities and underrepresented communities to forge a further trust amongst the healthcare system. And that's kind of like been a large experience that I experienced with my family and just general people I talk to in the community.
I agree. That's a really great point, Kim. I think that is still like being studied, and definitely people have shown that when there's a like a race concordant provider, there's better care, there's more trust. And so the representation point is very powerful. I agree. Okay, I'm not sure if anybody else has any more thoughts or questions. Otherwise, we're good. Thank you, everybody.
Thanks, Katie.
Great talk. Thanks, Katie.
Okay.
Thank you.